let's get through the next talk. I think this is something that is also a topic of a lot of concern and discussion currently for a variety of reasons, and it's this issue about patient satisfaction and what can we do to measure it and improve it. This really hit home a few years ago when my daughter, who was 12, needed to have her tonsils taken out. And here I am, an anesthesiologist at a major medical center, and her surgery was scheduled for 9:30, and we got to the hospital at 7:30, and everything went well. We were in the recovery room by noon, and at 3 o'clock I was home. And she was on the family room floor, and she was comfortable and sleeping, and thankfully the procedure had gone extraordinarily well. And I was supposed to fill out the paperwork for the visit, which included the patient satisfaction questionnaire. And even though I'm a doctor and I do anesthesia, I was so relieved that she was home safe that everything about the hospital experience didn't really mean much, because I was so anxious and so relieved that we were home safe that I basically checked off that I was super satisfied with everything. And I don't think I'm the only person that does that. I think most patients, when they go to the hospital, it's the most important event, maybe in their lives, certainly of that year. And the anxiety, and then to know that they've been able to survive the surgery and the anesthesia. So how do you measure the satisfaction of patients when you have this huge confounder, which is the anxiety? And there's lots of confounders like that. I think what's changed now is that, as we heard earlier, some of the government payers and some of the commercial payers are using measures of patient satisfaction as a way to figure out how much to provide in reimbursement. And one of the tools is HCAHPS. How many of you use HCAHPS at your facility? Okay, okay, wonderful. I think in terms of the learning objectives, one of the things we want to talk a little bit about is the definition of quality, and this varies and depends on who, I'm going to say the customer is, kind of business school lingo. But when I think of patients and their impression of a high-quality anesthesiologist, I don't know that many patients who are having OR procedures even remember their anesthesiologist because they've had a midazolam as a sedative before going into the operating room. So you've got that initial challenge. Now in the labor and delivery suite, one of the great things about working there is that patients who get labor epidurals certainly remember us. But most patients that have an encounter with an anesthesiologist may not remember who that person was. And I think they tend to focus on things like bedside manner, maybe whether they had pain after the surgery, maybe whether they had nausea. On the other hand, surgeons, when they evaluate the quality of anesthesia care, I think they focus mostly on just how fast we are. You know, do we get cases started on time? Is our turnover, you know? And I always was put off by that a little bit because I was so proud of my technical skills or my cognitive medical decision making. But we do the same thing with surgeons. We usually evaluate how fast the obstetrician doing the cesarean is, how good they are, just how fast they are, right? So patients don't care about how fast I am in the operating room providing care, but surgeons do. And then you've got the hospital. When the hospital evaluates the quality of the anesthesia care as a group or individually, what do they care about? Well, they may focus on how many complaints they get about you or the group in terms of delivering care, maybe the cost of providing care to these services where there's low reimbursement. And then you've got the government who's trying to define the quality of anesthesia care. And all of you know that patient satisfaction has many confounding variables. So it's going to be difficult to detect changes in clinical quality by changes in patient satisfaction. And all of you that work on the labor and delivery know that there's little relationship between the score in terms of labor pain relief and the patient satisfaction once they get home. Why is that? Well, there's a lot of other factors that affect the relationship between pain, and there's been a lot of research by the OB community on that topic. And And I think the other reality that we have to sort of come to grips with is that assessing quality frequently is done with process measures, not necessarily outcomes important to patients. There's lots of examples of this. I was working with a hospital who had arranged to have a contract with the leadership of the hospital based upon the rates of nausea and vomiting in the recovery room by the patients having ambulatory surgery. So the idea is we're going to measure something that's important to patients, nausea and vomiting, and we're going to give the anesthesia group some incentive to reduce the risk of nausea and vomiting. Well, as they went to try to implement that, the first problem that they encountered was that how are you going to collect data from patients about that? I mean, are you going to have the nurses ask every 30 minutes, are you nauseous, are you vomiting? Or are you not going to say anything to the nurses about asking the patient? And obviously the incidence of nausea or vomiting in the recovery room depends on how many times you ask about it. So first you have to standardize who's going to ask, how many times, and what the question is going to be. Now, even if you figure that out, you want to have a system where the data about who is nauseous and vomiting in the recovery room is easily accessible from the electronic medical record. And the electronic medical records that are in most hospitals, it's actually a quite complicated informatics problem to extract which patients are nauseous or are vomiting, partly because the nurses may not document it, or if they do, they may place it in different parts of the architecture of the electronic medical record. So you have to be a pretty sophisticated computer scientist, believe it or not, with these modern electronic medical records to figure out whether a patient had one of those side effects. So as a result, because of these implementation problems, the hospital ended up with just measuring the fraction of patients that got an antiemetic in the recovery room, primarily because for sure that could be measured because that has to be, the medication had to be extracted from pharmacy, and you have to make a note of that in the medical record. So here we had an attempt to measure something that was important to patients, but we ended up with a process measure, which is antiemetic delivery, because of the reality of the challenges in measuring quality. Now, all of us that take care of patients in the operating room may be asked to work on a committee or a group that tries to improve patient satisfaction. And I think many of you are active or leaders in your hospital in tackling difficult problems. And I think the first thing we have to do is acknowledge the differences between being a clinician taking care of patients and being a manager who's trying to improve the system of care. It's two totally different types of work. So as an anesthesiologist or a CRNA, I know there's some here today, most of the time we take care of one patient, and that's a real treat. Most of us who take care of patients are doers. We value our autonomy. Unfortunately, oftentimes we're reactive in the way we manage our group and our practice, and we identify with our profession. I'm an anesthetist first, and we see ourselves as a patient advocate. In contrast, when you go to these meetings, you take on a different role. You have to put on a different hat, and unless you acknowledge this and are happy with it, you may be frustrated by how slowly things go and how difficult it is to institute change that's meaningful and lasting. And the reason is because as a manager trying to improve patient satisfaction, you're going to have to deal with lots of different people, other doctors, other nurses, hospital leadership, and you're going to have to be a planner. You're going to have to think ahead about the future and how you want to change things. It's very different from just doing something quickly without a lot of planning. A manager is going to value collaboration with a bunch of different stakeholders. Hopefully a good manager is proactive, and those managers in those meetings are going to identify primarily with the hospital, maybe more than the patients. They're going to be an advocate for organizations. And sometimes you get this crazy scenario where you have senior, well-respected clinician leaders who don't have a lot of success leading teams to improve something in the hospital. And it's this gap between being a clinician and a manager. Now, if you go to business school and you take a quality class, they'll tell you that there's 3 different ways of measuring quality. One is manufacturing perspective. What was done to the patient? It's process-oriented. So a great example of this is enhanced recovery after surgery. Those protocols don't really talk about what the patient should look like after surgery. They don't really talk about satisfaction necessarily. They talk about a pathway of care that's been predetermined by best practice that should be followed as much as possible. And so if you take a manufacturing perspective on quality, if the patient received all of the elements of the ARIS protocol, then you delivered high quality care. A different approach to quality might be kind of what's termed the structural characteristics, which was, it doesn't really matter what the care was, what really matters is what does the patient look like when they go home. And this is more outcome oriented, and it really talks about how well the patient looks relative to what the expectations were for a patient to go home. And then the third, yet different dimension to quality is the result. And this dimension argues it really doesn't matter what we did to the patient, whether we gave phenylephrine or ephedrine to the patient for hypotension after the spinal. And it doesn't really matter whether the patient had a post-dural puncture headache or not after when they go home. What really matters is were they satisfied with their care. Now, I think it's probably best to think of optimizing quality as requiring optimizing all three and not just choosing one. So I believe that to optimize quality in anesthesia care and medical care, you have to really optimize the process, what is done to the patient. That involves best practice and making sure every patient gets the best care as established by the best evidence. And then you want to figure out what the patient looks like at the end of the surgery when they go home and make sure that you're happy with their clinical outcomes. And then you also want to make sure that they're satisfied with the experience, especially now that that's being measured in a more rigorous way. Now, all of us know that quality is also dependent on perception minus expectation. And when I do cases, you know, my favorite kind of patient, I do a lot of orthopedic anesthesia now, and my favorite kind of patient is that somebody comes in for a total knee replacement, and I ask them, how did it go last time when you had your other knee done? And they said it went horrible. The parking was really far from the hospital. The intake unit was really rude. The anesthesiologist had to try 3 times to put my IV in. The spinal didn't work. And I had a chipped tooth. And then I went to the recovery room, and the nurses really were talking about me behind my back. And then I was in the hospital for 2 weeks. And I never recovered properly from that. That patient's expectations about that day when I take care of her are so low that I could really do an awful job and she'll probably think I'm really awesome because her expectations are really, really maybe inappropriately low. She just had a difficult time. On the other hand, my least favorite kind of patient is the same person who comes in for a total knee replacement, and I ask them, how did it go last time? And they say, oh, it went great. No problems. Everybody was super nice. The anesthesiologist did everything expertly. I had no pain, even though I'm on Vicodin now pre-op. I had no nausea, and I went home 3 days after surgery, and I'm playing tennis. If I do the anesthetic for the second patient the same way I did for the first patient, for sure, the patient satisfaction for that second patient is going to be different. So what do we do with those patients? Well, we manage their expectations. For that second patient, I say, you know, I'm so glad things went well last time, but this procedure is associated with some pain, and we're going to do everything we can, and I try to lower the expectations so that they think I do a better job. And I think all of us kind of do that when we speak with patients. You have to manage the expectations of the obviously the surgeons and the hospital, but also the patients to control the quality, and that takes a concerted effort for sure. Patient satisfaction has lots of confounders. The environment of care. So at Stanford, we have a freestanding surgery center off of 101 that was built a couple years ago. It's a beautiful facility. Everything is new. The carpet is perfect. Windows, light, fabulous place to practice and spend the day. Other parts of the hospital are in the basement. There's no recent remodeling. The physical plant just looks bad. And so you could have the same patient having the same surgery at the really nice place or the really ugly place, and they might ask you the quality or the anesthetic or the satisfaction of the patient with the anesthetic, and they're going to be colored or affected, confounded by the environment of care, even though I don't actually control anything related to the physical plant or where the surgery is. The affective care, you could do a wonderful job taking care of the patient, but if the patient has an inappropriate interaction with a nurse in the recovery room or on the floor, that's going to affect how they view their whole experience. And one of the things that all of you know, I'm guessing, is that typically a patient's perception of their hospital experience will be dictated by their most negative interaction. And I think that's true for us too, right? I mean, if you rent a car and everything is perfect, but the interaction with the person who was doing the paperwork was not optimal, that's probably what you're going to remember more than everything else that went well. And so if you want to improve the quality of care or improve the satisfaction, you have to pay a lot of attention to those tiny, short moments where patients have a negative experience, and those need to be targeted specifically. Flow and timing of care, you could have two cases. One starts on time, the other one starts 3 hours late because there was an emergency. I'm going to do the same type of care, but one's going to start later. I think most patients are really tolerant of that, but it may affect their satisfaction with the care. Now, all of you that take care of laboring patients know that pain control is only mildly predictive of maternal satisfaction with childbirth. This is due to lots of confounders, and I know people have done research on this, including the fact that the 0 to 10 pain score doesn't properly capture the dynamic, multidimensional, and progressive nature of labor pain. So when you try to compare the two, maybe it's more tricky. The race and socioeconomic level of the parturient is going to be a confounder. How involved the patient is in the decision-making is going to be a confounder. How much support they have by family is going to be a confounder in their experience. Communication and relationships with the caregivers is another confounder. So lots of things will make the assessment of the satisfaction of the patient tricky to measure. And then the other reality is that please, when you get satisfaction data about your patients, don't assume that it's real and truthful. And this is a mistake I've made over and over again. And this is an example. We do a post-op phone call to the patient, which is, how satisfied were you with the anesthesia services? I don't know that it's a great question, but that's sort of the question. And there are 3 answers: very good, good, and average. So for a 6-month period, this was the percentage of patients that answered very good for the NSE Dissatisfaction post-op phone survey question. So kind of like 85% of the patients responded very good when asked how happy they were with the, or how satisfied they are with the anesthesia. And that seemed fine. We wanted to improve. So we asked, okay, which cases are these that we're asking this? And it turns out that because of the way the survey was being administered, these results did not differentiate between cases with an anesthesiologist and cases without an anesthesiologist. Now, you might ask, how is that possible? Well, there's lots of cases, when I'm going to define case as a procedure, that are done in a hospital that don't require anesthesia care. They might be done in the GI unit without an anesthesia provider, or they might be in another part of the hospital. And there was no way for the way the query on the computer system to be written to differentiate those two. So you have to ask, where did the data come from? How is it measured? How do we know it's valid? And work with the informatics people to get valid and useful data. So it turns out that without doing anything, just by correcting how the query was written, our patient satisfaction went from mid-80s to mid-90s. That was a lot easier than trying to educate all the anesthesiologists about things that maybe that we could do better, It turned out it was a measurement problem, not a clinical problem. And this happens all the time and is so frustrating, so you need to stay on top of it. We've talked a little bit about HCAHPS. It's the Hospital Consumer Assessment of Healthcare Providers and Systems. And I know that a lot of you work with this. For those of you that don't, it's the first national standardized survey of patients' perspectives of hospital care. The public reporting of hospital scores actually begun 10 years ago. And for the past 3 or 4 years, the scores have played a role in hospital payment through the Hospital Value-Based Purchasing Program. And it's a 32-item survey instrument. It's administered between 2 and 42 days after discharge to a random sample of adult patients. And it can be administered either by mail, telephone, mail with telephone follow-up, or an interactive voice response. And this is the actual survey, page 1. You should probably take a look at this if you haven't already. The first section really talks about the care from the nurses. For instance, how often did, this isn't the CRNAs, this is the nurses on the floor. How often did the nurses explain things in a way you could understand? And then the next piece is your care from doctors. So, for instance, during the hospital stay, how often did the doctors listen carefully to you? And then the question that's gotten a lot of attention is question 13, which is, during this hospital stay, how often was your pain well controlled? It seems like a harmless question, but as hospitals try to increase the number of patients that say never, that can have unintended consequences, such as maybe too much opioids and patients that are overly sedated and the associated side effects of that. So I think there's more discussion about whether that's really the questions we want to be asking and being compensated for if they have unintended consequences in terms of sedation. And as these value purchasing initiatives link patient satisfaction to the HCAHPS, I think there's a lot of really good questions that we should be asking, and maybe even pushing back on this. Does catering to patient satisfaction have the unintended consequence of having healthcare providers offer unneeded care? If a patient asks for something that's really not medically indicated, I think some doctors may just do the extra exam or extra CT scan or extra antibiotics just because they want to have the patient be happy. How do we limit that? I think the other real issue is a reporting bias. I think that people that fill out these surveys typically are people either who had a really, really great experience or people that had a really negative experience, and everybody sort of in the middle may not answer it. So what do you do with data that really focuses on the two extremes? And I think what this leads to is that this clustering of scores at the high end, most patients are reasonably happy with their care. In terms of changes over time, and I'm sure you've seen this, a hospital may have some indicator. For the first 3 months, it was in the top 10 percentile nationally. The same indicator the next quarter, not much has really changed, is now in the bottom half of the country. Nothing's changed other than random variation. And how do you control for random variation in HCAHPS scores? Because very small differences will change where a hospital ranks nationally and even locally. Now, I know that some of you have probably visited this website, Medicaregov. Has anyone looked at the website to see what their hospital looks like on this? Okay, for those of you that practice in the US, you might want to take a look, because theoretically this is what patients are looking at. And when we talk about public reporting of quality measures, we're talking about a hospital putting measurements about its quality of care on a website available to anyone, which is really a daunting challenge to do that in a way that yields meaningful information. So this is a question that comes from the HCAHPS survey, which is, would you recommend this hospital to others? So the blue is our hospital, yellow is California average, and then the far yellow is the national average. Is it clinically different between the two yellows? Is there a real difference between the blue and the yellow? How does this compare month to month or year to year? One of the questions on the HCAHPS survey is, was your room quiet in the hospital? And this is a fraction of patients who said always. And so our hospital did poorly on this question last year. So there's been a big effort in the hospital to reduce the noise at night, which I think is a good thing, because I think patients should try to sleep. So it's odd to think about the fact that the hospital is trying to reduce the noise at night in order to improve their HCAHPS score. Here's the question about, was your pain always well controlled? What can we do to help with this measurement? We're working with the hospital continuously to try to improve pain management after surgery. Now, because of some of the perhaps weaknesses of the HCAHPS as applied to surgery and anesthesia, the surgeons working with the ASA have developed a surgical CAHPS, which is the Consumer Assessment of Healthcare Providers and Systems Surgical Care Survey. This is a way to try to tease out more surgical and anesthesia-specific issues that maybe the HCAHPS wasn't able to. And the ASA and the American College of Surgeons have worked on that. It's administered by the Agency for Healthcare Research and Quality. It's endorsed by the National Quality Forum. And 8 of the 47 questions are in the anesthesiology section. And I think we're still in the early stages of this tool, and I think there's more work that needs to be done. But this is the questions related to anesthesiology when we talk about the surgical HCAHPS. Number 18 is, were you giving something so you would not feel pain during your surgery? I sure hope so. Did this anesthesiologist encourage you to ask questions? Questions like this. And then they have this question 25. I don't know who wrote this. Using any number from 0 to 10, where 0 is the worst anesthesiologist possible. This sounds like a surgeon wrote this to me. And 10 is the best anesthesiologist possible. What number would you give? I mean, boy, is that where the state of measurement is nowadays in 2017, that we're asking a question like this? It does bring up the point that is, unless we take control and ownership of the questions that are being asked, questions that we may find unsatisfying maybe become how we get paid. Lots of acronyms of quality, and it's a real daunting challenge to stay on top of all this stuff. So let me just finish by saying that even though I think we have some idea of what outcomes are important to patients, the day-to-day measurement of quality by hospitals and anesthesiologists and anesthesia groups is frequently done on process measures. And if one of those process measures is the Surgical Care Improvement Project, and if you look at the list that was available even 2 or 3 years ago, quite a few of those have been removed, because it turned out that that process measure really wasn't what everyone hoped it would be, and there were unintended side effects of measuring things. And so it's a moving target. What might be a useful process measure today that's being used for reimbursement next year may be deemed to be inadequate. And I think it speaks to the basic fundamental work that needs to be done to understand the connection between process measures that we can measure reliably and valid and outcomes that are important to patients. And just to finish up, the Medicare.gov site does have lots of information about different things, and I encourage you to look at that when you have time. Thank you very much.